Okay, I think we can start. So good afternoon, everyone. Welcome to this new session of the Spring Seasonal Risk Forum. We are very happy to have you here. You know, this forum is now kind of tradition. We have on the second day of the IRCAD course. It's a combined session, online and face-to-face. We have more than 200 attendees that are connected today online. The principle of the forum is really to have an interactive session to involve everyone, especially our students. So my first recommendation, please everyone feel free to ask any question, to join the discussions. Don't be shy, because it's really the principle of the forum. Today we have Lorenzo Bernini that will manage the chat. He will forward, if he agrees, any question you would like to ask. And from now, we will have 1.5 hours together to spend. And we can start right now with the Kimbok session with Michel Levadou and our experts. Thank you.
Thank you. I'm very pleased to be with you to this session on Kimbok disease. You know, Kimbok disease is a very special disease, and there are many things in this disease that we do not understand. So I hope that arthroscopy will be able to answer to some question about this disease. And for today, we get 3 experts from Japan, France, and Spain to speak about this pathology. And so this is my great pleasure to introduce Professor Shohei Omokawa from Nara, from Japan, for arthroscopic approach and biomechanical perspective for Kimbok's disease. Thank you very much.
Thank you.
Okay.
Okay. Okay. Bonjour. I'd like to talk about the arthroscopic approach and biomechanical perspective for Kimbok disease. The arthroscopy in carpal bone necrosis can help decision for surgical selection. And you can see the video. This is a Pricer disease. We can see the bleeding, even if the MRI is completely low intensity. The articular cartilage is damaged in Kimbok disease also. Dr. Ben classified an arthroscopic staging, and the cartilage will be damaging from proximal to distal. The surgical selection for Kimbok disease is divided into 2: lunate preservation or lunate resection. Preservation procedure include revascularization by vascular bundle or vascularized bone graft, and also the compression procedure can be decompress the lunate and can be preserved lunate. And the lunate resection procedure include the lunate resection alone, with or without partial arthrodesis, and proximal row carpectomy. And the revascularization procedure for osteonecrosis was developed in Nara in Japan by Dr. Hori and Dr. Tamae, and in 1979. So I like this procedure because I'm from Nara, and I published several years ago to report that, and vascular bone graft for Kimbok disease. This is an 18-year female badminton player, ligament stage 3C. And the palmar and fracture fragment of the lunate dislocated palmarly, and very difficult case. But we try to see the cartilage for her, and even if very, very displaced, but the cartilage is only softening, no evolution. So this patient is very young and active. I tried to preserve the lunate. The vascularized bone graft from palmar distal radius was applied based on the imaging technique, like a downside, and we confirmed the connection between the anterior interosseous artery and the radial artery, and we take a vascular bone from here to the lunate, and from the palmar approach, I reduced the fragment and fixed by the vascular bone. And the vascular bone graft was successfully fused the joint, although the cartilage was damaged post-op because the palmar cartilage status was very bad intraoperatively. But functional outcome, 2 years were rather good. The pain is gone and the DASH score reduced. And now, because I am from Nara and I need to continue the vascular bone graft, but I thought the less invasive technique should be done. I'm afraid, but I hope Dr. Tamai is not angry to me. And arthroscopy, the judgment of preservation. If the preservation is okay, I can decompress the lunate arthroscopically. And if the preservation is not okay, resection can be performed by arthroscopy. And our arthroscopic treatment strategy for Kimbok disease is lunate decompression by resection of the proximal capitate and arthroscopically, and the lunate resection alone is conducted for advanced Kimbok disease. And this is a candidate for preservation of the lunate, active and young adolescent, congruent joint, no fragmentation, positive bleeding from the lunate, healthy cartilage. We can do arthroscopic decompression like this schematic diagram. This is a 72 years male golfer. He's old guy, but every week he play golf, enjoying. And so we observe the status of the cartilage, and the incongruity here is the mid-carpal joint, and the cartilage was gone at the proximal side of the capitate. And in the radial carpal joint, the softening was observed, but rather healthy at the radial carpal joint. And so I tried to resect the capitate here like this to just decompress the lunate. And he was very happy post immediately and to relieve the pain, and still playing golf every week now. And this is a 57-year male with stage A Kimbok disease. This is pre-op MRI, and after resection of proximal capitate, and the MRI restored, the vascularity was restored 20 months post-op. And this is a candidate for lunate resection. The low activity and elderly, incongruent joint, the fragmentation like this, a negative bleeding from the lunate, degenerative cartilage, arthroscopic resection can be done like this. This is and we can preserve the connection between the scaphoid and the trichotram, like this schematic diagram. This is a 71-year female with stage 3C Kimbok, and the lunate resection was done because of the damaged cartilage and also the fragmentation of the lunate. And the post-op, immediately, and we have no immobilization post-op, and the pain was reduced, and the score decreased also. And I'd like to talk about the surgical pitfall of arthroscopic lunate resection alone. This is adequate resection, but this is inadequate. The dorsal fragment is too large, and so patient is complaining pain when he extended his wrist. And so this is only one patient with have a necessity of the secondary surgery. And this is patient summary. Resection is 14 patients, decompression 5 cases, and follow-up, mean follow-up is about 3 years. The result is so far so good. VAS reduced, DASH reduced, PRW reduced, and the grip strength and the range of motion increased, and the carpal height rate decreased significantly. How is the long-term follow-up about this procedure and lunate resection alone? And I have only 7-year follow-up case for the longest case, but Dr. Blanco from Spain published a long time ago the open technique, and even if open technique and the lunate resection alone is very tolerable procedure. And the other arthroscopic surgical option is radial lunate fusion, like this. This is 30 years male post-Kimbok, and I conducted radial lunate fusion like this. If we can observe the bleeding from the proximal lunate, we can conduct the fusion arthroscopically. And I'd like to talk about the biomechanical perspective for Kimbok disease, and the lunate is the keystone. If what happened to the bridge if the keystone is missing? And my procedure, and we conducted a biomechanical study several years ago to see the effect of the proximal capitate resection, and the radial lunate pressure is decreased significantly, but the radial scaphoid pressure increased significantly. And this is another biomechanical study comparing the stage 2 preserving ligament between the scaphoid and the trochanter, the stage 3 total resection of the ligament, and in the stage 2 the scaphoid trochanter distance maintained, not separate. And also the arthroscopic resection minimized kinematic changes of the scaphoid and trochanter. And so I think the bridge no collapse, even if the lunate resection alone, when we connected the scaphoid to the trochanter. And I'd like to talk about the in vivo 3D analysis-based CT-based study. And this is an in vivo study. You can see the video comparing the Kimbok disease and the scapholunate dissociation. The time is okay. And in the left-hand slide video, this is a Kimbok disease, no subluxation of the scaphoid. But at the right-hand slide, this is the SLD, scaphoid subluxed dorsally. This is completely different between the SLD and the Kimbok disease. And the SLD, the dorsal subluxation, then also the centroid location is migrated dorsally. And in the Kimbok disease, just fraction of the lunate, no subluxation dorsally. How about the lunate resection arthroscopically alone? This is a video of the pre and post-op of the patient, actually, and in vivo animation. Even if lunate resection and the carpal kinematics, almost no change. No subluxation dorsally and no separation. between the scaphoid and the trichotram. How about the carpal bone axis in neutral position? The post-op, scaphoid flexed like this, and also the trichotram downward, and the very distance between the trichotram and the lunate and ulnar is decreased. This is a joint contact area before and after lunate excision alone. In the radial scaphoid and in the mid-carpal area, no change by the lunate reduction. However, the ulnar trichotram distance decreased post-op by the lunate reduction. How about the pros and cons of the radial lunate reduction alone and proximal low carpectomy? I think surgery time is better in lunate reduction alone, and also carpal height maintained, joint concavity maintained, but mobility is better in proximal low carpectomy. I don't know the stability, which is better. We need to conduct the experiment or some more work. In summary, arthroscopic approach for Kimbok disease, surgical procedure is selected based on patient characteristic, imaging, and arthroscopic findings. And arthroscopic surgery provided such satisfactory midterm functional outcomes, and partial capitate reduction in lunate facet had biomechanical effect of the lunate decompression. Arthroscopic lunate reduction alone, preserving carpal ligaments, minimized carpal instability and kinematic change. Thank you very much for your attention.
Thank you very much. If you accept, we will do the discussion after the free communication. So please, Jean-Michel, can you join us for the arthroscopic lunate excision pro and cons? You get 10 minutes.
Sorry. Okay, everything is okay. Thank you very much. I would like to thank my Japanese colleague for its wonderful presentation. So I will just report my experience of arthroscopic lunate removing for Kimbok disease. So we know the definition of Kimbok disease. It's an avascular necrosis of the lunate with possible healing and possible lunate collapse and arthritis. We have many different treatments for Kimbok disease depending on the stage of this pathology. Until a few years ago, we had 5 stages from Leachman classification, and 5 years ago, he had a 3C stage to this classification. So I'm going to speak about only 3A, 3B, and 3C now stage for my patients. So over the last 15 years, we operated 15 patients, 10 men and 5 women, mean age 37 years old with a follow-up of 39 months. For clinical evaluation, we had pain, mobility, strength, and a clinical score as Dash and Mayo wrist scores. For radiologic evaluation, it was Hume index score and radio scaphoid angle. So this is classical stage 1 without collapse, but in this stage we have fragmentation of the lunate, so it could be a 3C, and this is with collapse, a 3B, but it could be a 3C because there is also fragmentation. It's just like this. So surgical technique, we use a mid-carpal and radiocarpal portal, 3445 MCR and MCU, a usual tool for wrist arthroscopy, and a small burr, which can be helpful sometimes if you have some bone a little bit hard. So you can see here we are in the radiocarpal joint. There is a small point of arthritis on the lunate trochlea. You have lunate just over, and it seems to be intact with a beautiful cartilage, but there is a fragmentation, as you can see. And once you are inside the lunate, you can see that there is only necrotic bone. So you begin to remove your lunate using a grasper at the beginning, piece after piece. And it's not so difficult because with necrotic bone, it's not really any longer bone. And you will use also a mosquito to remove all the part of the lunate. And you can see the specific aspect of the bone, which is not really classical bone. There is no healing at all in this case. And even with the burr, when you remove the bone, you can see that it's very, very easy because it's a very fragile bone. So at the end, you have only a small part of your lunate. We are on the other side of the joint. And you can go from mid-carpal to radiocarpal joint. And here, this is the capitate. You have the M8 just near. And this is M8. And then trichotrom. And we remove all the lunate. And now we are in the radiocarpal joint. And no bleeding at all. So this is before and after surgery. After surgery, it's a splint for 15 days with self-rehabilitation, and we have to wait around 6 months for clinical result. It's about the same than for first stroke capectomy for clinical evaluation. So we have decreasing of the pain, increasing of the mobility and the strength with good clinical score. For evaluation with X-ray, you can see that there is no modification for the collapse with the same radioscaphoid angle and the same about Hume index. And after several months, there is no modification. So lunarectomy is not something new because before it was with open surgery, and in the 80s and the 90s, they had good results, as you can see, with pain, mobility, and strength. Everybody tried a lot of different techniques, even replacement of the lunate with implant, with silicone implant, or with tendon ball, or even with vascularized bone graft, with a lot of different results. Arthroscopy was used for diagnosis, to check the quality of cartilage, and even to try to define different classification. And at this time, there was no correlation between the aspect of the X-ray and the aspect during arthroscopic evaluation. Bain and Begg proposed this classification relative to the damage of the cartilage between lunate and carpus, or lunate and radius, and they propose an algorithm treatment depending on the injury of the cartilage. Until a few years, arthroscopic treatment was just synovectomy and debridement, but no real arthroscopic treatment. I mean, for some kind of important cartilage damage, it was open surgery. And we had a recent study from a Japanese team, which shows that with lunate replacement, we can get good result. And when we compare the two studies, the study from our team and the study from the Japanese team, you can see that we have also exactly the same result. That means we have decreasing of the pain, increasing of the mobility and the strength, and even with measurement of the different angles, we have the same result. So we can see that removing lunate and arthroscopic control is good for the pain. We have a result stable across years without progression of carpal collapse, you can have a lot of information about the state of the cartilage, and even if you think that there is still vascularization in your lunate, it's not so difficult to have no complication, and this is not a dead end because it's always possible to go on with other kind of surgical technique. Thank you very much.
We introduced Fernando Corella for arthroscopic proximal root carpectomy advantages and technical points. Thank you very much.
Okay, so thank you very much for the presentation and for the opportunity to be here with all of you. So my lecture is about arthroscopic proximal row carpectomy. So advantages and technical points. So this is the first question. Are there any advantages in performing these procedures in an arthroscopic manner? That seems not to be too easy. Well, through a dorsal approach, we have to open the skin, the extensor retinaculum, separate all the tendons, open the capsule, just to reach the bones and remove them. And I usually compare this with a mountain with gold inside. We can extract that gold in an open cast mine or in an underground mine. But in salvage procedures, all the mountain is gold, because in this procedure, in order to reduce the pain, we have to reduce the range of motion. And the range of motion, apart from the type of surgery we are performing, but for the scar tissue, won't be the same after an open dorsal approach than after an arthroscopic procedure. So, are there any advantages in performing a proximal root carpectomy arthroscopically? For me, the answer is clearly yes, because we have less scar tissue, but also we are going to respect the extrinsic ligaments, so we can begin an early mobilization, and also we will respect the proprioception. But it is worthwhile, this advantage is worthwhile because it's not an easy technique, it can be difficult. So I think we have to work on new technical details on how to decrease the difficulty to incline the balance to the right side. So this is why we published in 2017 this paper explaining how to perform an arthroscopic proximal row carpectomy, trying to finish the technique at least in one tourniquet time. So I'm going to talk about different tips and tricks for this technique. So firstly, let me talk about instrument. So for me, the most important tip to do this technique in one tourniquet time is to remove the bone really faster. So for that, we have to remove the inner portion of the bone with a bar, but not only using a 3 mm typical bar of wrist arthroscopy, but a bigger one of 3.5 or even a 4 mm bar. So once we have removed the inner portion of the bone, we have to remove the peripheral portion, the XL, with a periosteal elevator or a pituitary rongeur. So this way we can go really fast. So here you can see we have removed the inner portion of the lunate, and now with this pituitary rongeur we can remove the peripheral portion really fast. My second advice is to work in pairs. This is not an easy technique. If you do everything with one hand holding the camera and with other hand trying to remove the bone, you are going to get dirty the camera, you are going to get out of the grease. So it is really useful that one surgeon holds the camera with two hands and the other can even make a strong movement or precise resection with two hands, and this allows you to go really, really fast. And my third advice is to use volar portals. But why volar portals are useful for proximal row carpectomy? Well, for me, for three reasons. The first one is because you can work more comfortable. You are working with a colleague, he can work in the volar side, you can work in the dorsal side, you can check the arthroscope, so it's more comfortable not to work one to the other side, but just one in front of you. The second reason is because when you look from dorsal, it is easy to remove the volar portion of the bone. And when you look from volar, it is more easy to resect the dorsal portion of the bones. So here in this view you can see how we are looking now from the dorsal side, and we can remove the volar portion of the bone because it's just in front of your camera. was the lunate or the triquetrum looking from dorsal. But also we can change the arthroscope to the volar side, and now we are looking from volar, and it's much easier to remove the dorsal portion that sometimes it's really difficult to reach this from the dorsal side, like viewing and the resection. And the third reason is because we can work with two instruments at the same time inside the joint. And especially for proximal row carpectomy, this is important because we have to be really careful with the cartilage of the head of the capitate. If we use a really big bar and we hit the capitate, we have finished this technique. So we have to be really careful with this cartilage. So with two portals, we can introduce a periostal elevator and protect all the surgery, the cartilage of the capitate, and then we can use a bar under this or even a bigger bar without having the dangers of injure this important cartilage. And also, apart from this periostal elevator, because normally we do this with dry arthroscopy, but we put water just to clean the debris, we can also introduce synovium from the dorsal side, so we can clean the debris and the other surgeon can do the resection. So it's really useful to have two portals to work at the same time. And regarding the volar portals, which volar portal should we use? Well, for me, the most useful one is the volar central portal, because you can reach all bones, the ulnar bones and radial bones, and because the portal in the midcarpal joint enters here just in the posterior space, so you respect the radiocarpal ligament that are essential if we want to perform a proximal row carpectomy. This is the paper that we published, the description of the volar central portal. It's a portal that is 1.5 centimeter long between the distal grease crease and the proximal grease crease, and as you know, the lunate is just centered between these two creases, so all the flexor superficialis tendons are retracted towards the radial side, along with the second and third flexor profundus, and the fourth and fifth one towards the ulnar side. So this way we can enter both in the midcarpal or radiocarpal, but for this technique only with the midcarpal portal is enough. So this is a complete case of a Kienbock disease that we perform a proximal row carpectomy. The first step is to check that the cartilage is perfect in the radius. You can see all the fragmentation of the bone. That is the approach. Once you retract the tendon, you see by transillumination the capsule, so it's really safe. And you can begin with a big bar. You can see the periostal elevator is protecting the capitate. So we begin resecting the volar portion of the carpal bones while we are looking from dorsal. As I told you, we empty the inner portion of the bone, that is the scaphoid, and then we can introduce directly a pituitary rongeur to remove faster that peripheral portion, like it is if it were an Excel. So this is the lunate and the scaphoid. So just removing the volar portion of those bones. We can check change the arthroscope towards the radial midcarpal portal and do the same in the triquetrum. Again, using the periostal elevator, we can protect the cartilage, we remove the inner portion, and then remove the peripheral portion with the pituitary rongeur. So now we can change the arthroscope to the volar side. So now we are looking from volar, and the bones is just in front of you, especially the triquetrum that is really attached to the radiotriquetral ligament is useful to see from volar, or is from dorsal. And this is the final aspect, that is the radioscaphocapitate ligament. You can see it's perfectly respect, trapezium and trapezoid, the cartilage of the capitate that we haven't damaged, and the final result. We can remove traction and see if there is an impingement or any problems. And this is the clinical result of this patient with a really good range of motion and a strength of 20 kilograms. Only 9 less than the contralateral side. But we can do also this technique for other problems of the lunate. This was a patient with this range of motion and with this pathology. 4 months with a neglected treated perilunate dislocation. So he was in a huge pain, and when we scope the joint, we see that there was no lunate. The lunate was volarly displaced, impossible to reduce after 3 or 4 months. So we were able to perform the proximal row carpectomy arthroscopically. Even in this case, you can see there is the lunate, and this is the final aspect with the capitate perfect and the scaphoid and lunate fossa, and the final aspect of the X-ray and the clinical result. This is just 1 year after surgery. You can see a good range of motion and the scar of the volar central portal. You can see it there, and a grip strength of 27 kilograms is not bad. And the X-ray. Also, in other problems like this, arthroscopic ligamentoplasty was performed in another hospital, but the tunnel in the lunate was just crossing the mid-carpal joint, so it was a fragmentation of the lunate. You can see the graft just crossing the mid-carpal in the middle of the lunate bone, so this kind of disaster. So we removed the graft. There was a hole, so we couldn't do anything, so we performed again a proximal row carpectomy. So that is the final aspect. And the X-ray, and this is only 10 weeks after surgery. You can see the scar still red, and with a good strength of 23 kilograms, only 10 weeks after surgery. And this is our longest follow-up case. It was a slack grease, but you see the X-ray 2 years after surgery, 4 years after surgery, and 8 years. And there is no progression in the arthrosis, and a really good range of motion for a proximal row carpectomy, and a strength of 34 kilograms is good enough. So the take-home message for this lecture is, for me, there are clearly advantages of performing the proximal row carpectomy arthroscopically. Less scar tissue, early mobilization, respect the extrinsic ligament, and respect the proprioception. We have to continue working in technical details to decrease the difficulty. That way it will be worthy to do this technique. And my advice to do it in one tourniquet time is to remove the inner portion, not only with a small bar but with bigger bar, and then the peripheral portion with the periosteal elevator and the pituitary rongeur. You have to work in pairs, find a colleague as skilled as you, and work one in front of the other. And for me, the volar central portal is useful to decrease the time you need to perform this technique. Thank you very much.
Any question on the floor? Sorry.
Yes.
Mario.
Oh, yes. Thank you for these great 3 talks. I have some 2 questions. One for the lunate resection. Did you report any influence of the lunate type on the outcomes, and do you have any advice for that? And a second question for Fernando. What is your advice, to remove the more distal part of the scaphoid?
In the middle, yeah.
Okay. So, yeah, I think it's important to remove the distal part of the scaphoid. Yeah, because in radial desviation, sometimes it can touch. So, yeah, it's important. Maybe it's the most complex part to remove arthroscopically. So, for me, the tip there is to go with a really thick periosteal elevator just in the STT and push down. And then from volar, you can also remove the last portion of the tubercle. Yeah, but I think it's important to remove it. If you waste a lot of time, you can perform a small approach in the volar side and just remove it.
Yes.
And
Jan?
considering the lunate type, is there any influence? Sorry, Jan. I would like to know.
In the middle.
Okay, about the technique of the lunate resection. And firstly, I mark the membranous portion and SL and LT. And then I first, from the mid-carpal volar, the resection of the volar portion of the lunate. And then the pitfall and I showed, and those are part is very sometimes difficult to resect. And so I switched back technique like Dr. Correa. I use sometimes to see that those are fragmented by volar portal. That's
So, Jan.
I have a question. For proximal row carpectomy, do you always use to do a radial stylodectomy as well? it didn't show, but I think that's an important thing to do, but you don't do it? Okay.
No, I don't do it. It depends also on the pathology. But if the capitate is have contact with the lunate fossa and everything is okay, and in radial deviation the trapezoid doesn't, and the trapezium don't touch the radial styloid, I think I've never done that.
Thank you for your nice presentation. I saw in one of your cases for the lunate dislocation or subluxation, but even though you resect the first row carpectomy, why? It was not enough to remove only the lunate?
Yeah, unfortunately I don't have experience in removing only the lunate. I don't know, maybe now after all the biomechanical studies, maybe it will be a good option. But for me, at least until now, when I have a problem in the lunate, I remove the complete proximal row carpectomy. But it can be an option, sure.
So, please, is Emmanuel Camus with us because Emmanuel Camus is with us for the... Yes. Ah, yes, Emmanuel.
Yes. Hello, everyone.
All right. Do you have any comment, any question with your camembert?
Yes. Yes. Actually, I don't practice camembert under arthroscopy because it's intra-radius osteotomy. But three very important and exciting lectures. I would like to ask to Jean-Michel. He explained us his trips, his ticks and trips, and I tried after his explanations. I tried to do some, but sometimes I think you can keep the living part, distal part of the lunate. What do you think about that? Maybe, and in my smallest than yours experience, if you remove only the dead part, the proximal part of the lunate, it could be enough to try to maintain the maximum of connections between scaphoid and triquetrum. So what do you think about removing only the dead part?
In the case I operated, there was not at all bleeding in my lunate, and most of the lunate, I mean 90% of the part of the lunate, was totally destroyed, as I showed on the video. But you can see the aspect with CT scan before arthroscopy, and we had an important collapse of the lunate with an important destruction of the lunate. And when we go inside the wrist with your camera, you see cartilage which seems normal, but nothing inside. It's like an egg without anything inside. And as I'm operating many scaphoid non-union, I said to myself, oh, if there is something bleeding, maybe I could put bone grafting to see what happened. But in the case I operated on, there was no bleeding. So if I find it, maybe I could try this, yes.
Okay. And to Jean-Michel too, why do you think you have an increase of grip strength after lunarectomy? Because of loss of pain or something else?
Yes, it's only pain.
So
okay.
I have the same question than Emmanuel Camus for Professor Okawa and Jean-Michel Cognier. If we keep the volar and the dorsal part of the lunate, is it more for necrotic issues or more for stability issues?
To increase
if you keep
grip?
Yes, you keep the volar and the dorsal part of the lunate.
Mm-hmm.
It is to preserve the ligaments. That is the only...
Yeah, as much as possible, I try to preserve the ligament. But even if I think, and even if the total reduction of the dorsal pole of the lunate, if the ligament and deep portion of the DIC ligament trochlear lunate scaphoid ligament is intact and they don't open. And so, but I try to preserve the small part of the and palmar and dorsal pole of the lunate.
Only the cartilaginous parts. You don't do that in your technique?
No, sometimes you say, okay, it's beautiful cartilage, beautiful ligament. Maybe we couldn't let it just like this, but how it's going to live, I don't know. So I think we don't have enough experience to know what is better for the patient.
Okay, thank you.
So I think that there are some questions.
Yeah, many questions from the online participants. First question from Alejandro Badia for Professor Omokawa.
Yes.
He's writing, do you think the lunate revascularization is due to the mechanical effect of capitate head resection or an hyperemic effect as described in core decompression radial metaphysis?
Well, both, but the main effect is the decompression and to the lunate. And Dr. Moritomo from Osaka, Japan, tried to open the capitate selective shortening procedure and thought that the arthroscopic resection did the same effect for his procedure, and so I tried arthroscopically, mainly the decompression, mechanical effect.
Okay. But are we talking about the same thing? I think because the core decompression, as it was described arthroscopically, it's a bit accurate inside the lunate. And here we are talking in your technique about a decompression, mechanical decompression.
Yeah, as a result, revascularization is possible.
You associate with a curate core decompression inside the lunate?
Yeah.
Okay.
All right, another question from Chile for Jean-Michel. How do you best address the long radiolunate ligament after lunate resection to prevent an ulnar displacement of the carpus?
I don't know, but we didn't have any translation with a follow-up on 39 months. But one of my associates will see back all the patients. So we'll have some patients with 10 years follow-up, and I think it will be very interesting to see 10 years after what happened.
Okay, and any thoughts about placing an interposition?
I don't think it's necessary. It was done before with open surgery, and I'm not sure it's going to change something. Because once you remove your bone, it's not because you are going to put some small part of ligament without any mechanic function that you will prevent any collapse. And when you're operating stage 3B, you have already a collapse. So nothing happens after.
Okay, maybe one question for the whole panel also. Is there still a place for vascularized bone graft in Kinbach disease, or do we have enough answers, technical answers between arthroscopic techniques and conservative techniques?
I do need the protected narrow rule for especially younger patients, 18 age and 20 age. No, we need to make a much effort to preserve the lunate, even if challenging for younger. Yeah.
I have a technical question for Fernando and Jean-Michel. Do you have any tip, any advice when you resect the lunate not to hurt the capitate because you use 4 millimeter burrs? And it's very easy to. I'm always afraid about this. Of this.
Yeah, I totally agree. That's the main problem, because if you hit once, the capitate is a terrible mistake. So yeah, my advice is to use always a periosteal elevator just under the cartilage of the capitate, and use that big bar with 2 hands, because if you go with 1 hand and something happens, you can go. So when you are using such an aggressive bar, you have to hold the bar with 2 hands and always put the periosteal elevator in case you make a mistake, you hit the metal but not the cartilage.
my last question for Fernando. Yesterday you told me why should we do a lunate excision. Are you going to perform now after our lecture today?
Yeah, I think there are really nice biomechanical studies, so maybe yes.
Any question from the net?
One last question, yeah. Long question from John Campson. For everybody. He says, hi and thank you for the great presentations. Okay. Most lunarectomies have done work well, but they occasionally don't, and the commonest reasons appear to be in those who have short ulna or where the scaphoid has not fully flexed as it does in the typical collapse pattern. So does anyone have an idea why it could be so? And how to select at best the patient for this technique?
Do you think you have enough level of evidence to select young patients for your technique? That is the question.
Yeah. Is there some case where you won't do lunarectomy because the scaphoid is too flexed or not flexed enough, or is the ulna too short or too long?
So with all the classification without the stage 3C, I operated on stage 3A and stage 3B. So two different cases without collapse and with collapse, but each time with fragmentation of lunate. I operated only fragmented lunate, okay? And I didn't choose saying to myself, oh, it's stage 3A, I don't want to operate. Indication, it was because of the fragmentation and the pain from the patient. And we didn't increase the collapse until now, but we have to be very cautious with that and waiting for the 10 years follow-up to be sure of the quality of the treatment.
Yeah, even if the maximum fraction of the scaphoid, the congruency maintains, but the pressure between the scaphoid and radius increase, and we may need to diffuse the radius scaphoid joint in the future, and also the ulnar aspect, the tricutrine and the lunate ulnar pressure increasing, and we can do the wafer procedure for that case, I think.
There is no. Sorry.
My question for everybody. The biggest trouble I face is when I get a 20-year-old manual worker or construction worker and he presents with a 3B or 3C. And you're always concerned, I want to give him the best outcome, not just now, but 20 years from now, because the life is ahead of him. And all these procedures, we don't have any 20-year-old or 10-year-old follow-up, so you don't know what's going to happen, and you want to salvage the wrist, and not just any salvage, you want to keep it working for years to come. So anybody has any tips or tricks or any idea where we can preserve the wrist for a young manual worker?
Yeah, I usually do distal radius osteotomy in young patients. Even in advanced cases, if you have a short ulna, I perform a distal radius osteotomy and wait and see. No, so I don't go in young patient for proximal root carpectomy or nothing aggressive. Always try to do the osteotomy, and many patients, in fact, the lunate is collapsed. Wait, because at least in my experience, pain improves a lot. So yeah, even in young patients, I try to do distal radius osteotomy.
Have you faced any patients who didn't improve after radial shortening osteotomy? You followed up and
that I have to make a proximal root carpectomy. No.
Thank you very much, everybody. We are going to go to the case report and the discussion. So
now we move to the clinical case session. We ask for this session, for this spring session, some of our students to join the discussion. We have Francesca, Ideo, Michel Krambik, and Abdelrahman Al-Maridi. Thank you for accepting, and all our faculties. The first case, the topic today is the worst disaster you have ever faced and how to manage them. And the first case, I think, will be the case of Shihab Taleb from Mulhouse. Hello, Shiab. Is Shiab with us?
Hello, Alan. Thank you
Hello, how
for
are you doing?
welcoming me with you.
Thank you.
Do you hear me well?
Perfectly,
Can
Shiab.
you hear me?
Yes.
Yeah, okay, fine. I will share my screen, maybe it will be better.
Yes, Shiab, you share your screen, and could you stop sometimes during the case to ask our student to participants to comment the case, please?
Okay, I will. So, let's share. So, do you see my lecture? Okay, fine. So this is a case I had to manage 1 year ago. It's a 60-year-old man. He's right-handed, retired. He was an engineer. He wasn't a heavy worker. And he was suffering from his wrist for more than 6 years, more or less. So I had this X-ray. So the first question I would ask for the young panel would be, what kind of treatment or other imaging would you advise in order to get further in the case? This is the first question I would ask regarding this X-ray.
Just with the X-ray, do we have an MRI, Shiab? Just with the X-ray?
So the question was, would you go to an MRI or a CT scan? This is the first question, in fact.
I think we can ask, Michel is already ready to answer the question.
I would say it would also depend on the clinical examination, because but now we see it in the clinical examination, so it's pain on the dorsal-radial aspect.
Yeah.
So I think I would go for a CT scan in this case. The only thing is, do you need the contrast or not for the CT scan?
Okay.
So CT scan for, and on the side.
So I agree with you. So I did an injected one, and here is the injected CT scan. And as you can see, we have an osteoarthritis between the scaphoid and the radius. And what would be your main concern when you see this picture? The guy is, of course, suffering directly in front of where the CT scan shows you there is some osteoarthritis. He's young, physiologically young man, even though he's 60-year-old. What would you do for this guy when you know that he already tried the painkillers, the cast, and everything has failed, and now he's really complaining about this wrist?
I guess if you have no mid-carpal osteoarthritis, you could do some mini-invasive approach. You could do an arthroscopic styloidectomy, for example, and maybe even do a radial scaphoid interposition with an anchor, as we learned today.
Okay, fine. I see you follow the courses instead of me, unfortunately.
For Francesca, Abdelrahman has another option, or
why not go for a PRC? Proximal
PRC. Yeah, I know. So I go back in of course you can make it, but I was really concerned about the fact that when I saw the CT scan, there was only a tiny aspect where something couldn't fit to an healthy wrist. There was only a small part of osteoarthritis. So as your colleague, I was concerned about doing something as minimal as possible, because the guy didn't look as a 60-year-old guy. He was more around 50. So I wanted to jump to a mini-invasive surgery.
Sorry, I'm sorry. Just one comment. I think we really need more. We need more information if we want to make it interesting. Maybe you can help us with more information about the clinics, and we can go back to the X-ray. We only have a few frontal view from the arthro CT scan, and to make the discussion, Shiab, I think you can help us. We are several that thinking that it will be helpful to have a little bit more. So you have this, this arthritis, but do you have any other slide from the sagittal view, or can you help us a little bit if you want to discuss the treatment?
Just some...
In fact, sorry?
some precision are asked about the clinical assessment in the first place, especially, and some precision about the imaging, please, if you remember.
So, as it was written at first concerning the clinical one, the wrist wasn't as stiff as we could imagine at this age. It was 60 degrees for the flexion extension. The prosupination was complete, and he had already experienced only painkiller and cast treatment, and the pain was localized only on the dorsal-radial aspect with a small swelling in front of. This was the clinical aspect. And the guy was only complaining about this. So why did I put this X-ray? Because there was no dizzy, no VZ on the other ones. That's why. And in order to make a synthetic and small case, I wouldn't put thousands of pictures. So in the lateral view, you have nothing really different. I mean, there was no dizzy and no VZ, and the capitate, the aspect of the capitate was preserved. So that's why I put those ones, not to push you to others' direction. That's why. So sorry, maybe I could have put the lateral ones of the CT scan, but sorry, it's too late.
What is your diagnosis?
That is a question.
Where is this arthritis from?
Yes, but excuse me, Marion, we have to ask our student and our faculty what do you think about the faculty, please? What do you think about the case, and how would you move on in the diagnosis and therapeutic option, please? Jean-Michel or? Yes.
An infiltration of the radiocarpal joint. Infiltration. Because.
Ah, because.
So Jean-Michel, he already went to the rheumatologist, and the rheumatologist did once, and then tried the painkillers, the cast, and didn't work.
Okay, even if he went and saw a rheumatologist, you know that most of them, they don't know how to perform any infiltration. They don't use X-ray, so it's not really a treatment. So I always ask infiltration under radiographic control.
Please, thank you, Jean-Michel. Please, the second row. Would you want to comment on the case and what our students and Shiab told about this case, please?
Hi,
Dr.
Shiab.
Smith.
Hello.
Hi, Nick. How are you doing?
Hi, how are you going? So it looks to me, I mean, you can't tell for sure, but it looks on the lateral X-ray, it looked like there was dizzy. It looks like a slack wrist. And I think probably on the CT scan, I can't see very well from here, but about a grade 2 slack wrist. So I would additionally do motion X-rays, which may help you with the alignment, and also if there's loss of the radial side of joint space. But the next thing is maybe something arthroscopic for me, an arthroscopic evaluation to see where the cartilage is on the capitate, how much, if the lunate fossa is okay, and then you can have a discussion with the patient about what he prefers, strength or motion.
Okay, thank you for the commenter. Arthroscopy idea, and we have a question on the first row.
No, why we cannot use the hyaluronic acid injection? The same as
Shiab hyaluronic injection. What would you?
I have no experience concerning this. I know that in the knee surgery and knee osteoarthritis, they have a huge and long experience about this. But in my hand, I haven't experienced this, so I can't answer you back for this.
Thank you,
for your question. Sorry.
Could you move to because there is.
Yeah. So as Nick advised, I did arthroscopic assessment. And this is what I saw. This is the 1-2 portal on the radiocarpal aspect. The camera is inside the radiocarpal joint. And as you can see, you have an osteoarthritis with a mirror lesion between the scaphoid and the radius. And the other movie is showing you that there is no scapholunate ligament anymore. So as we could guess on the CT scan, we have an evoluted slack wrist lesion. And concerning this, what would you do when you have to face this? Would you stop the arthroscopy? Would you talk to the patient that maybe you can do something in the same surgical time? What would you do for the treatment of this lesion and this patient, of course?
For the student panel, we have Michel. He wants to answer.
I think we finally got a diagnosis and we see what's wrong with the patient. But what would concern me a little in this patient is he's male, he's 60-ish, he has a quite good mobility, and I wonder what his expectations would be, because I'm not sure that he would be easily happy with something, and I wonder what he would want. Would he want something that's more definitive? Would he want something that maybe would work, but maybe not? So I think a good consultation with this patient is essential to obtain a happy patient. That would be my major concern here.
What are the expectations for your patient, Shiab?
Pain relief. Pain relief, because the motion is okay and he's a rain relief, and the pain for him is really a problem, because he can show you that it's only on the dorsal radial aspect, and so he's focused on this.
Yes, but that's not only the thing you want to discuss, because every patient wants pain relief. That's obvious, but they don't know. Patient does not know what we are thinking, what the thinking process we are going through. So I think this kind of patient, you have to offer your thinking process. What can work? What is the chance of it working? What is the chance of you have to go back with a new operation? So I think a lot of your decision will depend on that.
I think we will see the end of the case, and after we will comment, because it is not. Could you show you, Shiab, please?
And go forward. So.
Yes. The results and what you did.
What I did, and I will tell you in the real life how I talked to the patient, of course. So I did a styloidectomy, and the purpose of the case was to discuss the indication of styloidectomy, in fact, because in my hand, I have some concern about posting the good indication of styloidectomy, the good technical pitfalls of styloidectomy, and I thought that clinical case dealing with this aspect would be interesting for me as well, and for the young surgeon, because when we saw a slight lesion on X-ray and people who are complaining only on local aspects of the wrist, you can it should be seducing for you to make only a small surgery as a styloidectomy. So I did styloidectomy, and this is what happened 2 months after. 2 months follow-up after the surgery. So I tried to remove only what I saw as osteoarthritis. I mean, on the scaphoidal aspect of the radius. And the guy came to me, and he was painful. The pain increased. He was stiff. The wrist was swelling, and he put the cast all day long. His cast. So my question, of course, is for the young panel would be. How do you think the follow-up will be for this patient? Do you think he can recover? Do you think it can be worsened? How do you think about this?
Yeah, Abdelrahman.
I would be concerned about complex regional pain syndrome. If my patient comes 2 months after surgery, swelling and painful and still in a cast, and I will be concerned about his range of motion. But I agree, if there was limited arthritis, even in a slack lesion, that you would try to do the minimal possible. But in this patient, if you notice the arthroscopy, there was a huge arthritic changes, not just at the styloid, but the whole scaphoid fossa on the radius. And that's why I think your patient is still in pain, because although you took out the radial styloid, there's still a big area of kissing lesion of arthritis that could cause the pain and explain the symptoms he's presenting with.
So you would have done differently in the first place for this patient?
I would go for explain the difference between four corner and PRC, and talk to the patient about what
in the first place.
So maybe also
Shiab, do you have something to answer to this?
So, in fact, when I talked to rewind just what I said to the patient, when I was the patient in front of me, he was concerned about the pain. So I explained to him that we have to wait in order to help him to make the good decision. So I saw him several times in a period of 6 months in order just to assess that he was really willing to do something. So, and in my mind, I wanted to start step by step. I mean, I thought that styloidectomy was the good first step in order maybe to decrease the pain and not to be so invasive as first row carpectomy or four-corner fusion. And I was thinking that it will relieve his pain enough to stop other surgeries. And in my mind, I thought that styloidectomy, for the final result, we need to wait for 6 months, more or less. So I wasn't concerned after 2 months that maybe there was a failure of the surgery. So when I saw him 2 months after the surgery, I just advised him to wait a little more. Of course, concerning the complex pain syndrome, I used to make always vitamin C before surgeries and let him taking his vitamin C for 2 months after the surgery. So I didn't think it was this kind of complication. But unfortunately, and this is my follow-up, 6 months after, he was still painful. And my concern on the X-ray was the position of the scaphoid, because I don't know if you remember the first X-ray, the scaphoid was not in the same position. And I didn't understand why the scaphoid was directly in front of the radius after my styloidectomy, because I thought I just removed what was needed. So this was my concern, my first concern when I saw the X-ray.
Thank you.
Because I just created another contact between the scaphoid and the radius.
Thank you so much, Shiab. Could you conclude the case, because I think it's not.
Yeah.
Oh, yes.
So I did the first row carpectomy because I wasn't sure he would have pain relief with the styloidectomy. He was fine after this. So just to sum up, I have only small things in the literature. Of course, I saw some paper from Melvin Rosser who said that you have good cases and good styloidectomy procedure with arthroscopy. And of course, of Guillaume Herzberg and Marion Burnier, but in my head, I was still concerning about the indication. So I was wondering if the panel could advise her concerning this technique. Thank you.
Thank you, Shiab. And I think there was one final comment, Jane, maybe you wanted to ask a question before?
Just wanted to tell my experience, and I agree with Jean-Michel Cognet, that in a 66-year-old man probably is not working anymore, so is doing only bricolage or hobbies. You maybe want to avoid the salvage procedure, so you can treat with injection, maybe cortisone first to avoid the inflammation, and then hyaluronic acid. I did this in one of my patients who went back to tennis and was very happy. Thank you.
Another comment, and after we move
yeah,
to
just the other thing I wanted to ask you, so I couldn't see it on the X-ray and the CT scan, what the STT joint was looking like if you did an arthroscopy there, and how the cartilage was looking like there, and then also I would have liked to know how the joint of the proximal pole of the capitate would have been, because I think also if the STT joint would have been affected as well, I would have probably gone straight for an proximal row carpectomy after trying injections of cortisone under fluoroscopy.
Okay,
yeah, sorry. It was a question. No, it was a question.
Yes.
Sorry.
No, it was just a question of how the SCT joint looked like, and if you did an examination under arthroscopy, or what.
Do you have any information about the arthroscopic aspect of the SCT joint in the first?
Yes, or on the CT scan, if you could see any arthrosis there, because
Shiab, do you understand the question?
No, I didn't scope this STT. It's not in my habit. So when I saw the CT scan, maybe it was my fault. I was focused on the radius and the scaphoid. So in my mind, I was thinking the problem was there. So maybe that was maybe you're right. Maybe the STT could be the key point of this case. So I should have maybe scoped the STT in order to see if the problem was there. Yes. And at first, injection with hyaluronic acid would be a great option as well.
And also the mid-carpal joint, because it was very important in this case to see the head of the capitate. And I think that if the head of the capitate is free of arthritis, for me the best solution in this case should be in a 66-year-old man to realize a very small synovectomy and not so large that you realize, and to realize an interposition with a tendon. and probably the guy will be very good now.
Thank you. We have a very 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 last question.
Very quick answer. Just answer
from
to
Marion.
Shiab. First, thank you for sharing. It was finally interesting, and your answer is. No, because I said it was hard at the beginning, but yes, thank you for sharing. And to answer to your question, it's when you have a pain in radial deviation and extension, this is probably when you have a greater rate of success. Really, when the pain is in this position. If it's a global pain, it's probably much more difficult to achieve good outcomes, except in the study from Rosenwasser. So
thank you, Marion. Thank you, Shiab. You stay with us if you want. See you. And now we.
Thank you.
Merci beaucoup, Shiab. Now we move to Dr. Jorquera case or Dr. Gomez. I don't. No, Dr. Gomez. Gustavo Gomez case. Gustavo, you are with us?
Yes.
Hello, Gustavo. How are you doing? Thank you for being with us.
Very good. Very good.
Could you please share your? Could you share your case, please, and stop sometimes to ask our students questions, please?
Yeah. Okay. Okay. Are you seeing my screen?
Yes.
Okay. Hello to everybody. Thank you for the invitation. It's a pleasure and honor for me to participate today with all of you. So I will show you a simple case. I will try to be fast because of the time. I want to show you a case that can come usually to our office. This is a 42-year-old patient, manual worker, right-handed. He was operated in another clinic for a distal radius fracture 4 months ago. So he came to us with this X-ray. He came with us with a pain of 2 points in the EVA scale. He had 26 degrees of extension, 23 degrees of flexion, 17 degrees of pronation, and nothing of supination, as you can see at the right of the screen, which was, of course, very limiting to all these activities of these patients. Fortunately, the patient came to us with the X-rays that he had previously to the surgery. In the AP view, we can see that we have central depressed in the scaphoid fossa prior to the surgery that they performed. And in lateral view, we can identify a volar fragment, a dorsal fragment, and a gap between them. So this was the first surgery that was performed on the patient in the other clinic. We can see that he has now 3 key wires that are doing completely nothing. And after the surgeon removed the key wires, we can see that we still have the central depression and a dorsal tilt of the articular surface. So I want to ask to the students, which will be your conduct in the future? What will you order right now to study the patient?
Is anyone? We have Francesca with us. Yeah.
Hola, Gustavo.
Hello, Francesca. How are you?
Very good, thank you. So I would ask for a CT scan, and maybe I would get some engineers to work on a good way to do an osteotomy to correct the volar tilt and also the interarticular step off, and I will probably use an arthroscopic assistance plus, of course, the open technique to do an osteotomy.
Okay.
To correct this.
And the drush. Yeah, great. There's a drush problem.
We have yes, and Ideo would like to talk.
I agree with that, your opinion. And before arthroscopy, I need Watson test because maybe the SL dissociation. I concerned about the SL dissociation, and I'll check Watson test, and I added the X-ray of grip X-ray. Yes, I did.
But do you think it's reliable in this situation, the Watson test?
Watson?
if you do a Watson test in this situation with a dorsal angulation, and do you think it's reliable at this point?
Do you think, Gustavo, could you help us? Our students are, there is a very little, they're arguing about the Watson test. Do you think the Watson test is reliable here?
Well, it's very difficult to perform a Watson test in this situation because patients have a lot of pain. We cannot touch the wrist. The patient have no movement. So it's very difficult to do ulnar and radial deviation to try to see the Watson test. So as Francesca said, our intention was to do arthroscopic surgery. So we will be able to check the scapholunate ligament because, as you said, the scapholunate ligament can be torn. So we can check it in the arthroscopic procedure. Okay?
May I make a comment on these X-rays? So this guy's concern is a cell dissociation. You must remember that looking at these X-rays, you see a scaphoid flexion, but you also see a lunate flexion. So the problem is basically, the appearance is basically a problem of projection, of view. So the whole proximal row is in flexion. It's adaptive posture following the malalignment of the distal radius surface. So in this way, the space between scaphoid and lunate has an enlarged, a widened appearance. It doesn't have to put in a mistake because it's very misleading and may make you think of a cell dissociation, but in fact it is not. So as Gustavo was stating, it's very difficult to assess an instability in a stiff joint. So probably arthroscopy will give you more details.
Thank you, Andrea. I think Margaret totally agree. Do you have something to add, Margaret, please?
Yeah, I would definitely do a CT first to basically see what is the articular surface looks like. Now, because I don't think that the articular surface is well, and there is probably some degeneration between the scaphoid and the scaphoid fossa. The second thing is I worry about pronation and supination. So is the screw in? If the screw is inside the joint, then that's why. Because usually you won't get the pronation and supination. So you need to take out the plate. I will take out the plate. I will do arthrolysis. I will assess the joint after CT, and then I will remove it, and I would basically rehabilitate the patients and see whether they have more pain. If they have more pain, then I may do a limited fusion later on, but probably not at the first stage.
Thank you so much. Gustavo, please, could you tell us what you did, because we don't have enough time.
And conclude, I know. I will try to be fast. Okay, so as you can see, you said everything. The CT scan that we already show us a big hole in the scaphoid facet with a central depression on an articular surface and an intra-articular screw in the distal radio-ulnar joint. So we can see a dorsal teeth, the incongruence of the articular surface, a dorsal fragment without fixation, and a screw affecting the ulna. So it's important to understand that this patient have an extra-articular deformity combining with an intra-articular deformity. So we have to treat this patient using a technique that combines both an extra-articular procedure and an intra-articular procedure. So it's a hybrid procedure, as Andrea told me once. So we start the extra-articular procedure doing a border approach, as you all know. We remove the callus, and after that, we make an osteotomy until the subchondral bone. Otherwise, if we want to subchondral bone from inside the bone, we can produce new fractures, and it's very difficult to follow the original fracture. So, as I said, we perform an extra-articular osteotomy following the original fracture. And after that, we go with the osteotomus through the epiphysis, making a road to the central depressed without involve the subchondral bone. Then we place a new plate centered on the epiphysis, and we move the tail of the plate to the diaphysis to reduce the extra-articular deformity. After we do this, we go to the intra-articular procedure, assisted under arthroscopy. So, first of all, we have to remove the fibrosis. We have to make some space working from the ulnar side to the radial side, removing all the scars that we can find in the wrist. So then we increase the traction, and we have to remove these fibrosis bands. After we identify the hole in the articular facet, as you can see here with the probe touching the articular surface, we remove the fibrosis to have a nice view of the articular surface. And then we complete the osteotomy from the articular surface, going exactly through the regional fracture to complete the release of the subchondral bone and elevate the fragment to reduce the step-off. This is a final X-ray. We can see now a volar tilt and a new screw fixing and holding now the dorsal fragment. We restore the shape of the articular surface, as you can see at the right of the screen. And the most important thing is to check that we put a screw underneath this fragment to avoid the collapse of the fragment after the surgery. Again, we see now that we reduce the articular surface with we have now no central depression with a screw below this fragment. And we have now a good congruence of the joint and volar tilt. And of course, we didn't put now a screw inside the distal radio-ulnar joint. So when we check the postoperative range of motion, we can see that we have earned 17 degrees in extension, 44 degrees in flexion, 56 degrees in pronation. And the most important thing is that we have recovered almost normal supination, and now patient is without pain. Thank you so very much.
Thank you, Gustavo. We are going to move right now, and I will present the case, but I think Dr. Jorquera is with us.
Thank you. Thank you. Okay. Hello, everybody. Thank you very much, Alan, for the invitation.
Hello.
You listen to me, yeah? Yeah, thank you. Like,
So,
I had any problems when my internet connection, please.
Thank you. I'm waiting the case to be shared. Thank you. So, up. I will take this. The disaster of Dr. Jorquera is the case of a young patient, a 37 years old woman with a history of 6 months wrist pain without trauma in the first place. The patient was treating with by another hand surgeon in the first place. The ultrasound showed was positive for a volar ganglion cyst, normal range of motion, Watson negative for our students, clinical ulnar impaction signs, and no DRG instability for the first clinical examination. So I'm going to move to the case, and in the conclusion, I'm sorry, to discuss the therapeutic option. Here is the first X-ray on the right dominant hand. And the patient is still in pain after some weeks. 20 physiotherapy sessions were ordered, and here is the MRI. One comment, please, from the student about the MRI. Who wants? pain on her side, and
there is like a edema or something in the radius. That,
and also
radius?
around.
Yeah.
That, I mean, doesn't really make sense, right?
On the radius, and what do you think about the first row?
Yeah, there's also edema on the lunette.
Yes, and can you share, please? And on the tricutrol, as well. Here is something. I think we can move directly to March the same year. The radiologist, the hypothesis is a Kienbock disease. We need to know that this patient has a history of von Willebrand disease. And the patient was addressed to Dr. Jorquera 2 years later, and for a pain in the whole carpus, and a DRUJ instability appeared. Remind that in the first place there was no DRUJ instability. Painful and limited pronosupination. Here is on the right the X-rays after 2 years. Remember, the first X-ray were totally normal when the patient was assessed in the first place. So, just our students, one comment, please, Abdurrahman.
Is this a bone infraction from what?
Sorry?
Bone infraction happened? What happened?
Nothing happened. The patient, this is the evolution in first consultation in February 2018, 2 years later, evolution.
She didn't have any infections or anything, no?
We will see. So I think we can move. That is the evolution, the X-ray, and antibodies were negative, rheumatoid factor negative, HLA-27 negative. And that is the aspect you have on the MRI. For the faculty, please. Someone has any comment? Yes, Jean-Michel. Synovite vilonodulaire. Dr. Jorquera, we have Jean-Michel Cognier.
Yeah.
He hypothesizes in March 2020. Comment dire en anglais?
Yes, you listen to me. Yes, the possibilities is that my first thing is infection. Discard of the infection. The carpus is stiffening and the carpus is painful, and sign of it is the first possibility. I don't in this moment we don't have the another diagnosis. It's the only diagnosis. We have assess of the another physician on the rheumatology, another physician and multidisciplinary treatment, and we don't have etiology.
Okay, thank you.
Precise of the etiology.
If you agree, we will move on. Thank you, Dr. Jorquera. So, what's happened after? Here are the X-rays, and the arthroscopy was performed in September, so 2.5 years later, with synovectomy, assessment, of course, of the cartilage. There is a huge synovitis, and for sampling for biopsy. Here is the aspects on the radiocarpal joint and the arthroscopy. Radiocarpal joint, huge degenerative changes. Here is the huge, the hemorrhagic aspect, red aspect, the synovitis, synovectomy, midcarpal joint. There is also some head capitate is not so bad, but trilateral space. And at this moment, here is the last imaging. Here we have our disaster. Someone from the right. What are at this moment all the biopsy were negative, no infection, no tuberculosis, because this aspect on the arthroscopy could be tuberculosis aspects. What are the treatment possibilities and the treatment options and after this disaster? On the right.
Maybe, but we still don't know what happened, but maybe wrist arthrodesis or...
We don't know. Dr. Jorquera did all the sampling and he told us there is no etiology found for this case. So fusion, complete fusion on the right, Francesca.
Yeah, she's very young. It's one side, so maybe it's a definitive operation for the rest of her life. So
I agree. One comment from Francesca, and after we go to the experts.
I also agree with the arthrodesis, although it depends on what the patient wants.
She's a young patient for not manual worker.
Yeah, if not, maybe you can even try a total wrist prosthesis, but if she's young, then you will have to change it in maybe 15 years, 20 years, I don't know, but if she wants to have a bit of mobility, could also be an option.
In one sentence, in Japan, what would you do?
Yes, so the most I want to know the etiology. So in Japanese orthopedic surgeon usually uses ultrasound assessment like Doppler positive, or I want to get some information about ultrasound.
But it's not enough for you, this image? No? To make her decision? One sentence from our expense, only one.
But he's waiting from the
no, he was talking, I think, about in the beginning. Now we have, so now, yes, now we have the advanced imaging.
Thank you for the case. It's so interesting. So I've had the exact same case, and we did biopsies. The CT scan is the same. And what was interesting is only the radiocarpal row was affected. We hypothesized, because the gentleman worked with tropical fish in aquarium, that maybe he got a bacteria that we never picked up.
That is.
He never, but all his results were never telling for bacteremia or. So anyway, so now he's cured. Like his wrist is cold, and I'm waiting to see if he's going to autofuse.
He had the antibiotics.
Yes, well, we did antibiotics.
Yes.
He saw microbiology
large
for months,
specter,
everything. So we're about 1.5 years, 2 years later, and I'm waiting to see if he's going to autofuse, or if I'm going to have to put a plate. But since we didn't know it was an infection, we haven't done anything yet. But I want to keep in contact with you.
We will. Thank you for the comment. Now the option compromise radiocarpal and midcarpal joints, unknown cause, maybe what you said. So decision to perform wrist arthroplasty by Dr. Jorquera here is the aspect, the pre-op aspect, range of motion in pre-op, very bad in extension. Here is the intraoperative view, dynamic fluoroscopy, and the intraoperative view. Here is the introduction of the implants, distal implant, and proximal implant here. We can set a common arthroplasty. The intraoperative range of motion with a fluoroscopy view, and finally 6 months later the outcome is quite good for the pain, for the dash, and here is the last clinical assessment for these patients. Thank you, Dr. Jorquera. Any comment from our students or our experts? I will take one comment for this case, or two.
I think he was lucky with the outcome, because if this was an infection that he didn't pick up, this would have ended up in a disaster.
Dr. Jorquera, our students are not so... Dr. Jorquera, we have a student who made a comment. What do you have to answer,
this
please?
Is my biggest problem in this case is we don't have the precise etiology. This is the problem. The tissue is negative in the infection, negative of the tuberculosis, negative of the rheumatoid. I don't know what is the silent infection in this zone. Very difficult. My patient, she wanted the replacement. I showed her the two options of the arthrodesis or the replacement. My patient, the decision is the replacement of the wrist.
Thank you so much, Dr. Jorquera. You know, the decisions is very, very difficult, especially in young patients. We have a very last question from the attendants, please.
One remark.
Yes.
I don't believe on the infectious disease. I more believe on a angiopathy or a hemopathy. So maybe it's ischemia, as we have it singular also on the tibia head or in the forefoot. And maybe this is a ischemia of the right hand, and we haven't seen it. So I would make an MRI of the head, because ischemias always make changes in the brain. And perhaps she has microparticles, macroangiopathias, and this was a microangiopathy, and we have not seen it because it had no infectious signs.
He did, I think. So, sorry, René, you did an MRI for the brain MRI?
Yes.
Okay, he did one, and everything was okay?
Yes, I have a one...
From microangiopathy, no?
From Willebrand.
There are associations
from Willebrand disease.
Thank you, Dr. Jorquera. I'm sorry, we need to move directly to Alejandro Badia case. Dr. Badia, are you with us? No?
Yes, I'm with you.
Please, Dr. Badia, we don't have enough time. Could you please present your case, and we will just comment at the end, please.
Okay.
Thank you.
All right, let me share screen. Okay, you see this okay?
Yes.
Great.
Perfectly.
Okay, so I hate to be reminded of this case, to be honest. But you forced my hand. So middle-aged, a band, a very famous band actually, fell 4 months prior to me seeing him, where he underwent ORIF, and he was apparently progressing well in therapy, but then referred to me by a colleague because of the deformity and the loss of reduction, but minimal pain, but he also had loss of thumb flexion. He is on an antidepressant. This is the X-ray, very concerning because of the screws. The surgeon told me that they were locking screws. This is a striker plate. Obviously, they did not capture this dorsal fragment, but you see the deformity, but surprisingly good range of motion. This is under fluoro that day in my center. I don't use much CT. I have in-office fluoroscopy, and I can see in many degrees. So I requested the injury films. This is what he initially had. This was a CT. You can see quite severe intra-articular. And the reduction here does not look bad. Maybe some concern over here, but good restoration of the volar tilt. But this is a follow-up. Now, the patient states, and I suspected some problems such as alcohol abuse potentially, and he may have had falls. So these screws here were backing out. And then these are the therapy reports saying excellent progress. He didn't cancel. He went to therapy. So everything was very surprising here. So I took him to surgery, but there was an economic problem. So I had to use the same plate because the patient couldn't pay for, and there was complete loss here of bone. So I put this screw to try to capture the radial styloid, and I used a putty for bone graft. And then I ended up I could not capture the dorsal fragment. So I was not at all happy with this x-ray, of course. This took me 2 hours, where I normally do a distal radius in about 25 minutes. So this was not a case I was happy with. The quality of the bone was very, very poor. Follow-up x-rays, you see increasing deformity, the plates not holding. All in all, a real disaster.
Yes. We can see.
So now look how bad this is. So now I had to remove the dorsal plate because I was concerned about the extensors. So this, yeah. So this is.
J'adore.
That was a small clue as to who this was. So anyway, for the students, you get this patient with fair range of motion, not so much pain. What do you do?
Thank you.
I really struggled in the surgery. So
for the students, I think we have the worst disaster here. What would you do for the students? I think Dr. Maridi.
If the patient has good range of motion and minimal pain, why touch him?
Dr. Badia, how was the pain, please?
Well, that's what I did. I did not touch him, but what I saw was the progressive deformity, and it became to the point where now the patient, the deformity was so severe that now the patient is worried, and of course, the friends and family say, this doctor did a terrible job, and honestly, I feel perhaps that's true. So at some point, deformity. Is important. I mean, after the face, the hand is the most visible part of the body. This was a celebrity person, so
nothing for Dr. Nothing for Abdelrahman and Michel.
But you don't have union, so something will go wrong eventually. And the ulna is also very subluxing, so maybe more tendon problems. I don't know. Something will go wrong. That's sure.
Yeah.
Wait.
Yeah.
I know it's expensive.
Yeah.
I know it's expensive in the United States, but I think you could get a CT scan on this if the patient can pay.
So, Dr. Badia, what did you do, please? CT scan or nothing?
I did not do a CT. I mean, it was the problem is clear to me without a CT. The thing is, when I spoke to the patient, again, because one of the colleagues commented, if he really doesn't have pain, and he had very good motion, very prominent ulna, it was very difficult. And again, I started realizing the social problems he had. I think very heavy drinker, and the bone quality was so bad. So to correct deformity at this point, to me, it would have been fusion, but it was hard to justify. So I think what I would have done differently is forget the problem with cost, and I would have used a different type of plate. I would have used, in this case, maybe I would have even used iliac crest and got into in this area. Gotten a block of bone to really support the radius because of the quality of bone, but I didn't go in intraoperatively planning this, and this is the problem. So frankly, I would have used this as a plate I'm using many times nowadays because it allows me to restore. The lever goes under the subchondral, and this was very, very rigid. So my solution to this would have been to do it differently from the beginning. But it's hard, it's hard to look back. And I didn't anticipate this events, but these things happen.
Thank you. So now, how is the patient? It was in the 2015.
I honestly suspect that maybe he's not even with us. The guy was I realized was a disaster. I'm not sure.
Maybe.
So I don't know. He has not come back, and I have not heard anything about it.
Thank you so much for this disaster, Dr. Badia. I think it was. We were very happy to see you. I take only 2 short comments, please.
Okay.
He was first.
Well, it's a very clear case of interarticular non-union with deformity of the fracture. So why not to do revision? Remove all the plate and screws and do bone grafting and new plate.
Because the patient was gone. It's gone, the patient.
Yes, I agree.
Yes, perfect. Yes, of course.
I agree. I agree. But I don't think he really wanted to do anything else. As I said, I don't know if he didn't have pain because of an alcoholic neuropathy or something. Again, sometimes we have to look at the patient.
One more question. Do you sometimes in those cases consider like a spanning plate?
Spanning
or have
plate,
you have you
yes.
considered it? Because it came up my mind when I saw the pictures.
Dr. Badia?
Yeah, well, of course, if I had seen that there would be this severe radial collapse, then but I could not anticipate these things. I personally am not a big fan of spanning plates. I've had fractures that are much worse than this, that somehow I've been able to get together, and I feel that you get a lot of stiffness from a spanning plate. So, I haven't, I really haven't used it, but I understand, many people like it, and I have no criticism.
Thank you so much, Dr. Badia. So now, if you have any news from this patient, please.
Well, it was 10 years ago, so I don't think so. Hopefully not.
Thank you so much. Can I have the last picture? So really, we need, thank you everyone, we need to close the forum for today. Thank you everyone for the cases, for the comments, for the lectures, the lunate excision. The next forum here is scheduled in November. I think we will have another interesting topic. In between, so we don't say goodbye until November. We have all the IWC online meetings. So every month, the IWC Clinical Cases Symposium, it's very interesting with our fellows and discussion with the senior surgeon. The Wrist Journal Club is coming back every 2 to 3 months. So if you want to follow us, to join, you can follow us on the Instagram. We have a LinkedIn account. And for the replay, we have the YouTube. And the last thing is a 5-minute surgical technique contest. Every month we will play one of the video of our fellows. And we will vote in November for the best video. We will note the aesthetic of the video, but also the originality of the technique, etc. So today, to say goodbye, we will play Mort Hanifa video. He's a Istanbul IWC fellow, and he will present a very nice technique of scapholunate dissociation stabilization. So once again, thank you, and see you very soon.
This video demonstrates the spherical technique of suture button fixation and arthroscopic dorsal capsuloligamentous repair in chronic scapholunate dissociation in a 29-year-old male. He had long-standing chronic wrist pain following trauma. Wrist radiograph showing widening of the SL joint and increased SL angle with DC deformity on the lateral view. CT scan showing no obvious bony changes. MRI showing SL and LT ligament injury and dorsal capsule detachment. This technique is contraindicated in irreducible carpal malalignment or degenerative changes in the mid-carpal or radiocarpal joints. The reducibility can be assessed by performing a 4D CT assessment preoperatively. Examination of the radiocarpal joint with the standard 3-4 and 6R radiocarpal portals shows that the dorsal intercarpal ligament was torn and SL ligament torn over the radiocarpal joint. Arthroscopic examination on MCU portal show bachelor grade 4 SL injury, evident by the positive drive-through sign over SL joint, LT step off, floating lunate with rocking chair sign and drive-through sign over LT. Next, traction is released and the hand is placed on the operating table. The 3-4 portal incision is extended. Extensor tendon, EPL and ECRB are retracted. Then, the dorsal capsule is opened over the scapulonate ligament. We use the second generation IRCAD-IWC system. A small skin incision is made at the level of the volar radial aspect of the STT joint to allow exit of the guide wire and for passage of the suture button. A 1.1 mm guide wire is introduced through the 3-4 portal incision towards the volar radial aspect of the distal pole of the scaphoid. If available, the direction of the guide wire can be determined with a jig system. The guide wire is pulled back slightly from the distal exit side. A polling suture is passed through the K-wire's nitinol loop and the guide wire's opposite end is pulled, bringing the suture completely through and existing at the distal pole of the scaphoid. Then, the nitinol loop of the K-wire was cut. The suture button device is passed to the polling suture. The polling suture is pulled towards the 3-4 portal, taking the SB device through the tunnel along the scaphoid. The first button is anchored on the distal pole of the scaphoid. The position of the first button is checked under the fluoroscopic image. Then, the proximal part of the lunate is exposed. A second guide wire is then directed towards the tricuspid from the lunate. Its position is confirmed under fluoroscopic control. The guide wire is further pulled back slightly from the exit side. The suture button device is again passed through the nitinol loop of the K-wire and the opposite end of the guide wire is pulled, bringing the SB device completely through and existing at the volar ana side of the tricuspid. The second button is then anchored on the tricuspid. The SB system is tensioned. Reduction is achieved by tensioning the system and checking under fluoroscopic after the first knot is tied. Then, multiple knots are securely tied. This is the final fluoroscopic image after tensioning both suture buttons, showing a reduction of the SL joint and SL angle. Next, the reduction is checked arthroscopically. Following suture button fixation, no more dissociation or steps were seen. Then, the dorsal capsuloligamentous repair is done for biological healing. The sutures are passed through the dorsal capsule and the remnants of the intrinsic ligament via the 3-4 radiocarpal portal. Then, both distal sutures are retrieved by two different portals in the distal transcapsular area at the MCR portal. Similar techniques are used to repair LT ligament. Traction is then released and the wrist is extended to tie the last two proximal strands via the 3-4 and CR portals. Post-operative, we apply a cast for 3 weeks followed by 3 weeks of splint. This is the final radiograph image post-operative. This is the dynamic 4D assessment post-operative showing restoration of SL dissociation. This is our patient who as fitness instructor, currently able to return to work and lift heavy weights. The other patient is a basketball athlete who could return to sport after this operation technique. We call this smiley SB technique for smiley face. In conclusion, this is a minimally invasive good surgical technique with good short and long-term outcome for chronic reducible scapulonate dissociation. These are my references. Thank you for your attention.